Good.
Is that okay if I start?
Yeah. Do you mind if I just?
Oh yeah.
Thanks. No one can take the place of Dr. Barrett Casson, but we'll try our best.
Except for Dr. Boyd.
Except for Dr. Yeah. Barry, where are you? Okay. Really delighted. I'm John Boyd, for those of you who don't know me. Really happy Sekhon agreed to. I promised the residents in ICU right now that this would kind of blow their minds. But they're already like post-call and sort of tremulous, so we're not sure. But anyway, Mip's the new head of the division of critical care as of this year, and great energy and change has been super already. Mip's a translational researcher. He did a PhD in integrative physiology after his training. Finishing his UBC critical care fellowship, he went over to Cambridge and did a neurocritical care research and kind of developed a great program in translational research, brain injury, and he's going to show you what's coming out, I think this month in Nature Medicine.
Next week, yeah.
Next week, okay, yeah. But a program of research which we're hoping to actually begin here as well as a site, and so just want to really thank you for coming. Thanks a lot, man.
Yeah, thanks, John. Appreciate it. I'm going to give more talks at St. Paul's because it's like, it feels good when John says nice things about you, you know? It's like it never happened during fellowship. So this is a welcome change. Okay, so I'm going to talk to you about, this is not meant to be morbid, but we're going to talk about the physiology of the dying process. This is a ubiquitous event in life. 96% of people who've lived have experienced this. The 4% are the current group of humans that are still alive on Earth who were yet to experience this. And little is known about it. Not many people give me money, so I have no disclosures. What is death? It's this unique concept that forms the interface between a lot of different facets of society, encompassing the medical sciences, legal implications of when a human has passed. There's philosophical considerations that have perplexed smart people for hundreds of years. And of course, it interfaces with theology and spirituality, as well as cultural beliefs. All of that melts together into what the concept of death is. There is no uniform aspect or definition when you consider all these realms. I'm going to focus on the medical aspect of this to kind of keep it a bit more simple, though. The history of death research, advancements in death science has gone on for thousands of years. But if we fast forward to the 1600s, that was the first time that the circulation of the human body was discovered. That the circulation, that our body functioned off of a circulatory tree that was carrying red stuff around from organ to organ. Fast forward from then to 1900, that's when the Cushing reflex was described for brain death. After World War II, the Nuremberg Code for the ethical considerations of how we should do research upon people from the atrocities that were committed during the war. 1958, Peter Safar in Pittsburgh discovered mouth-to-mouth airway resuscitation. The first time that a human could have died and then been kept alive again and revived. Closed chest massage was discovered a couple years later in 1960, which led to CPR. The first heart transplant, taking in what we think is maybe the center of life, the heart. And it's awfully rich of me to come here to the Heart Lung Institute, right, and give this talk, because I'm going to make the argument that the heart is not the center of life, but it's something else. But the first heart transplant occurred in 1967. And then in 1981, the Americans developed the Uniform Determination of Death Act. In Canada, we don't have a statutory definition. In the US, they do. And it reads as this: an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of functions of the entire brain. That is super weird, because how can you be dead two ways? So what they're saying here, and this hasn't changed, is that if the heart lungs give out, or if the brain gives out, you're dead. But something such as death, why is there not a uniform, agreed upon criteria, manner as to when that happens? It gets at the heart-brain axis, the two most vital of all the vital organs. And we ascribe a lot of terms to the heart. Heavy heart, to indicate heartache. I heart you, love. My goodness, like the whole month of February is an amazing marketing campaign for Valentine's and St. Paul's that is centered upon the heart and ascribing feelings to the heart, a change of heart. That person is kind-hearted. What does that mean? Like, does the heart experience any of those things? Each and every one of those things that I've just showed you there, those are brain emotions. They have nothing to do with the heart. They're brain terms. Instead of being I heart you, it should be I brain you, right? I have a heavy brain today. It's a change of brain that I just had. So if we think of what our brain is who we are as a person. It governs your memories, your relationships, your movement, the ability to eat, sustain homeostatic functions. It governs who you are as a person. You can have a heart transplant. And does the person change? Of course they do change because they've been through all that. But it's still the same person. So if it's the person that defines what is life, then death should be defined as when that person is gone. As such, a brain term. Okay, let's talk about a case. So this is Michael. He was a patient of mine in February 2023. This is an all too familiar case, I'm sure, which you've heard of many times. Poor gentleman. He was 26 at the time. He had a cardiac arrest. Day 6, his MRI came back as hypoxic ischemic brain injury. And his parents made the very difficult decision to proceed to palliative care. But they also wanted him to be an organ donor. So donation after cardiac death is what we used to call it, DCD. So we tried to do that. Those of you who have seen this process, we extubate, provide the patient with palliative care. If they pass within a 2-hour period, they can be considered an organ donor. If they don't, then they time out. Okay, that's what happened to Michael. So we extubated, provided him with palliative care as we normally would. He kept his heart and his lungs kept working after the 2-hour period. So we went to go tell his parents that it wasn't going to work out. He wasn't going to be an organ donor. And his dad said something. And David, his father, said this. He said, well, no, you don't understand. He said, we've looked into his eyes. He's gone. And what seemed like an innocuous comment at the moment kind of hit us as we were leaving the hospital, my colleague and I. What is the eye? The eye is the only physical way to look inside the brain. And that is because at the back of the retina, the optic nerve exits from there, goes through the optic chiasm, through Meyer's loops, and then terminates in the occipital cortex. It's one of the quickest and easiest ways that a neural pathway intersects all the important areas of the brain. The midbrain as well, or the brainstem as well as the cortex. That's what you are assessing when you're looking into someone's eyes. The definition of death in Canada is defined as this. It is the absence of brain function. And the absence of brain function can occur once circulation has ceased. That is our conceptual definition. However, how we practice at the bedside clinically is very different. So for DCD, patients have an arterial line. We wait until the arterial line reads a pulse pressure of 5. The critical assumption here, though, is physiologically what is seen at the artery is simultaneously reflected as what is happening in the brain. Is that in fact the case? In 1783, Alexander Monroe of the Monroe-Kelly doctrine told us it wasn't. They're not the same circulatory bed. And at that time, he stated this: the quantity of blood that circulates in the brain is greater than most organs of the same weight. Thus, one of our arms will be found to weigh more than our brain and cerebellum. Yet the area of the two vertebrals and internal carotid arteries, so the cephalic vessels joined together, the area is far greater than the proper subclavian. This was the first time that somebody had made the observation that perhaps the brain circulation was different than the extracranial circulation. Fast forward to 1897, James Cappy said this: my critic thinks there is nothing essentially, or nothing very essentially different in the circulation of the brain from the circulation of any other organ. I am greatly surprised by this statement. And he went on to refute how the extracranial circulatory bed and the intracranial circulatory bed are not the same. So coming back to what David, Michael's father, said, he said, remember, we looked into his eyes, their son is gone. He had deduced that his son had passed, and we took a picture of the monitor with their permission, and that was the blood pressure. So even while his son had a heart rate of 66, blood pressure of 75 on 36, the person who knows this patient the best, the parent, had surmised that his loved one, his son, was gone. So here we have a father making an observation that is counter to what we do in medicine. And that's what kind of got us thinking, well, how can we study this to reconcile this difference? What is the dying process? As I said, the dying process is ubiquitous. It's going to happen to everybody. If we think about it physiologically, though, it's actually also a stimulus, and a stimulus that is grounded in cerebral ischemia, brain ischemia. Arguably the most important mechanism in the body, when the most important organ is lacking the most important molecule, that being oxygen. And as such, it's an opportunity to study the response. Brain ischemic disorders are ones in which, unless you act quickly, i.e. you do CPR right away, or patient gets TPA for a stroke, brain ischemic disorders, we have not solved. We have not figured out. It is a type of pathophysiologic mechanism in the human body that we have nothing for. There's no medication we can give for it. There's no preventative vitamin you can take. And the way to study it is to do it in a human. And I'll show you how. That's what led us to this study. So when we kind of came up with this concept of studying the human dying process as a model of brain ischemia, we thought, okay, first and foremost, can we even do this? Is it possible to study the human dying process? If it is, this is very exploratory. Let's start with timing and a very exploratory look at, like, how long does it take? When do the different organs shut down in reference to one another? 3, can we use this as an opportunity to identify a blood test? Every day you check liver enzymes, creatinine, troponins. Why don't we have a blood test for the brain? The reason we don't have a blood test for the brain, because it is unethical to make the brain ischemic and then sample somebody's blood to then see what the proteome is showing. But this is a natural period during which this is happening anyways. Can we identify a blood test that you can use? Imagine a day when you can say, let's send off a brain panel. Let's see what the brain panel shows, or the brain troponin. And finally, we do autopsies, and I'll show you a little bit of that. So how do we do this? This is the model of how we do it. There's an automated robotic transcranial Doppler. So we don't have to sit there at the bedside, and we place it on the patient's head, and it goes zzz, 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 and it reads the posterior cerebral artery blood flow velocity and the middle cerebral artery blood flow velocity. And the reason for that is we want to know about the front of the brain and the back of the brain. I also place a retrograde central line. So it goes in the jugular vein, but it goes upwards. And it sits at the sigmoid sinus. And it reads oxygen saturation as it exits the brain. Think of it as the Swan-Ganz of the brain. And then we also do place a real Swan-Ganz the other way. So then we're comparing heart to brain, and then telemetry and arterial line and all that. And then we just take care of the patients as they normally would. Get a blood sample before, as they're passing away, and afterwards, and then they go on to have an autopsy. So this is kind of what this looks like. On the left part of the screen is the Doppler. They look like two stereo boxes. This is a Swan-Ganz catheter going down, and then a jugular venous bulb catheter going up. So reading analogous values of oxygen saturation in the venous circulation. So we're measuring brain blood flow velocity and a surrogate of oxygenation. And then I don't probably need to show you what a Swan-Ganz catheter looks like. You guys know that. But there it is in one of the patients, passed all the way down. I probably didn't insert it quite far enough, but that's the proximal pulmonary artery. So with this, we're able to measure mechanical and electrical heart function. This is what the bedside looks like in the intensive care unit of a patient who's going to pass. And you might say, well, that's crazy. Like, who would ever consent to that? On the y-axis are the individual patients for the first 32 with their adjoining disease states. HIBI is post-cardiac rest brain injury, but there's some traumatic brain injury patients, there's some sepsis patients. And on the top here are the individual data points. So ECG, arterial line, MCA and PCA blood flow velocity. SJVO2 is that catheter that goes into the jugular vein. PAC is a pulmonary artery catheter, so that's the Swan-Ganz. And then note the biomarkers and autopsies. A couple things I want to highlight here is the orange are data points that are collected per case. And there's a ton of feasibility here. So this is actually probably the most important finding, is that, you know what? Yeah, we can actually study this in medicine. You can approach a family, you can get consent, you can comprehensively study this process that we know very little about. Now, secondly, now that we know that we can study this, can we draw some insights into timing? This just shows, broken down by disease state, from the time of extubation to when the patient actually passed away. The data is all over the place. So there's no pattern by disease state, which is important to know, but this is wild. T0 now is a time at which blood flow velocities ceased in every patient. In the black is the time from then to when pulselessness was detected. In pink is a time from then to when electrical asystole occurred. So what this is demonstrating, again, a lot of heterogeneity, but it's demonstrating that the brain is losing circulation before the rest of the body is. It could explain why non-shockable cardiac arrest rhythms, i.e. from overdoses, have inherently worse outcomes, worse brain injury than shockable ones. It's not hypoxemia. This is something that's so poorly taught in medicine. It's not hypoxemia. Hypoxemia is not dangerous as long as you have flow. I can go to Everest and sat in the 70s, my brain will be fine. I'll be talking. That's because I have cardiac output. But when you're hypoxia is different than ischemia. Hypoxia tolerable, ischemia not tolerable. And this may explain why we see those discrepant differences. These are the individual blood pressures at which, in each case, at which the brain lost blood flow velocities. Note, there's even one where it was 150 on 80. Now, that happened to be a patient who had really high intracranial pressure from a brain bleed. Okay, now I've shown you some non-invasive data. So these are data that we're like, you know, put on the, there's an ultrasound based, and it's not, but it's not the real thing, it's a surrogate. So part of what I did in the UK was learned invasive neuromonitoring. I was an aspiring neurosurgeon until I realized most of that was outpatient laminectomies, and so I switched. And so we placed parenchymal monitors into some patients. So the CT scan there shows little catheters that are sitting in the brain that read ICP, oxygen tension, blood flow. And we've done a series of cases in whom these patients already had these catheters in as part of their care, and then we just got consent to leave them in during the dying process after the prognostication was poor. In each and every case, The red arrow signifies when in green, the oxygen tension of the brain. Now, this is a catheter sitting directly in the brain tissue, reading oxygen. It goes to 0 before the heart gives out. Seen a different way, we actually now do this in a more complex way. Now we get consent to do this upfront in patients who don't have the catheters in place, but we place these catheters in both sides of the brain. And that's what you see on the top G panel there. These are wires sticking out of the brain in this particular patient. I kid you not, this is what the patient's head actually looks like with all the monitoring. And here the catheter is sitting in both sides. We do a CT perfusion and map the blood flow pre. And this is pretty wild. What you see here, I want you to focus on these 3 panels. This is oxygen tension in the right brain, oxygen tension in the left brain. At 10:32, oxygen tension gave out, went to 0, but the pulse pressure, pulseless electrical activity didn't occur till 10:44. So that is approximately 12 minutes. That's a huge amount of warm ischemic time very important for organ donation medicine. One other thing that we do is we dialyze the brain. One of the catheters that sits in there has an isotonic fluid that goes in, it comes back out, and then we measure what's in it. And one thing that we've seen now in a number of cases is glutamate rises. So at death, there's a release of a ton of glutamate, and glutamate is an excitatory neurotransmitter. I don't know what it's doing, but there's a rush of excitatory neurotransmission that is released at the time of death. So when people talk about seeing the light or life flashing before their eyes, like maybe there's some truth to that. This is what some of these more invasive cases look like. They're done in the operating room, okay? And here's all the people on a Saturday morning. Here's the patient's head on the other side of the drape. And for the first time ever, I think what we've captured is the moment at which blood flow ceased in a human being in the brain and oxygen tension at 12:42. In this particular case, we had placed an EEG wire in the brain. And what you'll see here is the polarity of the brain became negative. That means blood flow ceased, oxygen went to 0, ion gradients, the ion pumps, energy dependent ion pumps stopped working. So there was coupling between hemodynamics, electrical activity at the same time. That's never been shown in the human brain before, to the best of my knowledge. And then after that, glutamate again skyrocketed. This is a different case. So fascinating in terms of describing this in the human body, because this has implications for stroke medicine as well. We see a big rise of glutamate, like glutamate is an excitotoxic bad thing traditionally, right? Perhaps part of the reperfusion injury is that now there's a big pool of glutamate sitting there. You open up an artery with TPA and then you just flush it. And it's got a bunch of gasoline of glutamate there. Like perhaps we should give ketamine or something to block it. I don't know, but there's some therapeutic implications there. Okay, I'm gonna jump through the rest a little bit more quickly. Physiologic relationships. A couple of things I want to highlight here is middle cerebral artery blood flow velocity and the posterior cerebral artery blood flow velocity. When you plot them against mean arterial pressure, or i.e. blood pressure, this is the only case I'm aware of where the human body has been taken down to as close to 0 as possible, right? So our ability to assess the whole range of blood pressure, the relationship, there's a lot of heterogeneity, but it's linear. So this goes against a lot of what we've been taught in medical school and a lot of what I propagated as well, that the brain maintains stable blood flow through a wide range of blood pressure. Not really the case. That literature is wildly outdated. Just jump through this. Okay, how about oxygen extraction? So like I said, we've got a Swan-Ganz catheter in place, and you got a catheter here, both in the venous circulations. As the oxygen delivery in the body goes lower, i.e. cardiac output goes lower, oxygen should get extracted out of the circulation. That's what should happen, right? And what we show here, though, is in blue, that happens at the level of Swan-Ganz catheter in the heart, but it doesn't at the brain. So what that means is that oxygen is not being extracted out of the brain as well. Now, why could this be? I suspect in our cohort, this is probably because these are largely brain injured patients. So like the gentleman sitting right next to the stairs is not extracting oxygen right now. You can see, like, I don't know. Oh, no, see, he just started extracting oxygen. Okay. I'm just going to jump through this. A couple other things real quick. Okay, who's seen agonal breathing? All of you, right? Everyone's seen agonal breathing. Yeah. So what is happening in the human body when agonal breathing is occurring? In yellow is the pressure in the heart or in the pulmonary artery with every agonal breath the person takes. So that's why it goes a bit negative. In purple is the blood flow velocity to the back of the brain in the PCA. So why is this occurring? Probably because as you take a breath in yellow, the central venous pressure goes up, so you drag some blood flow back to the heart, and then it goes through the lungs, and then it shoots up just a little bit of blood flow to the PCA. And what does the PCA and the posterior circulation do? Well, the posterior circulation supplies the brainstem. Could this be yet another reason why we know in shockable rhythms for cardiac arrest patients, they have agonal breathing? In non-shockable rhythms, i.e. like drug overdoses, they don't as much. And agonal breathing could be our own mechanism by which, before Peter Saffer developed mouth-to-mouth respiration, that our body was just trying to limp along. Okay, I'm going to show you. Just jump through here because I'm going to show you a couple of videos. This is wild. We take care of our patients at 30 degrees, right? In the intensive care unit, everyone's at 30 degrees. Anyone know why? Dreaded ventilator-associated pneumonia, right? That's largely why. The brain is dependent upon perfusion, but gravity also plays a role in that. There's also this concept of head-up CPR, which as far as I can tell is just beyond stupid. But people are evaluating and trying to practice. So in some of the patients, this is what the transcranial Doppler looks like. On the left there is the posterior cerebral artery blood flow. On the right is the anterior cerebral artery. So what you're going to see here is this person is supine. Now, family's in the room, but we get consent to change the level of bed. So this patient is at 0 degrees right now. Okay, go. And then put him up at 30. Blood pressure is roughly about 70 on 50. Patient became apneic. Now I said, go back down. And then patient started breathing again. You might say, well, that's just one case. Here's another case. Again, PCA on the left. On the right is probably the M2 or the M3, distal MCA, okay? Supine right now, and then we go to 30. You heard a breath there? We go to 30 degrees right about now. And then we go back down to supine. Why are these data important? Well, they're important to show that even in the hypotensive shock states, that our brain at that low state is dependent upon gravity for that little extra bit of perfusion. So if you think about the intensive care unit, you know, people come in septic shock and all this sort of stuff, and then they're at 30 degrees because they're trying to prevent ventilator-associated pneumonia, even though that they're on broad-spectrum antibiotics. And then 2 weeks later, they're in hypoactive delirium. And then we're like, oh my goodness, let's give some haloperidol. To me, hypoactive delirium is ATN of the brain. The brain can't pee, is what's happening. And critically, in the bad shock state is when often the brain is hypoperfused. So what does this mean? It's not bad to put somebody down head flat, especially if they're in raging septic shock on 50 of norepinephrine or whatever. We just assume that what we see at the arterial line is directly reflective of what's in the brain. How about blood tests? Have we found anything? Long story short, not yet. I'm going to show you a bunch of proteomics and all sorts of stuff. Long story short, we've not found a brain troponin yet, but we've only analyzed proteins. So next week, we're starting to analyze some more metabolites. Nothing changed during the dying process of when the patient became hypoxic and ischemic and protein expression before and after. Now, on the other end of this, I'm not entirely surprised now. I was surprised initially, but we're not really, because you've got to undergo transcription, translation in order for the protein expression to change. And especially when energy is being depleted during hypoxemia and ischemia, that's probably not going to occur. But what could change quicker is the metabolite, the metabolome. So stay tuned. And the last thing is pathology correlates. We don't do autopsies as much anymore because probably our imaging has gotten better, our blood tests have gotten better, so we have an idea, maybe a better idea of what caused the death. But as part of the research, we do autopsies. What you'll see here in a couple cases is like the time interval is like very, very quick in a couple cases. This is actually super important for future research. These organs are then sectioned in paraffin blocks or in formalin, banked. And the importance of this now is I'm not aware of another body of work where you pair physiology to biospecimens to tissue, all within proximity to one another. Usually autopsy studies are so far removed from the actual insult, so it makes the tissue characterization of understanding disease mechanisms way more important. And sometimes we see things on autopsies that we did not come up. This is a brainstem hemorrhage, which showed up on CT as maybe something abnormal, believe it or not. But that is right through the reticular activating system in this particular patient. Sometimes we see things that are totally unexpected. This was a 34-year-old gentleman who was diagnosed with schizophrenia and tried to commit suicide. And he was married, but then estranged from his family and two daughters, 4 and 8. And he, so he, because of his mental health, tried to jump off a building. He had a traumatic brain injury. So the family asked that he be palliated. And so they participated in the study. This is a brain autopsy of all that brown stuff is a protein called tau. And he was a hockey player growing up, and multiple concussions. He actually had CTE, chronic traumatic encephalopathy syndrome, and that his schizophrenia was a clinical expression of his underlying CTE. So that was important for his family to know, for closure. Not that money is important, but he did have a life insurance policy that the company wasn't going to pay out because they said it was a suicide. But because of the autopsy showed CTE, that's gotten paid out into a trust for his girls. So, that's a research finding that's not a p-value or an odds ratio, but has real world implications. Last thing I'm going to leave you with, I talked a little bit about seeing the light or life flash before the eyes with all that glutamate stuff. And because we do measure the blood flow velocity in the back of the brain, remember with every agonal breath, there's a bit of squirt of blood flow to the PCA, and the PCA supplies the vision cortex. And in about 40% of patients, we see some stuff. In yellow is the blood pressure basically falling off a cliff. And we see these little rises of PCA blood flow velocity. They're probably super clinically insignificant, but they seem to be in a bunch of patients. So maybe there is something to that. Some patients, when they do wake up from their cardiac arrest, they say, oh, everything went blank, but I saw a bright light. Perhaps there is something to that. So at the end of the day, the comment, going back to the eye from Michael's parents, was that, yeah, we looked into his eyes and he is gone, even at that blood pressure. And his parents were probably right, that in their eyes, they knew their son had died based upon what they believed what death was. The picture of the eye that I showed in the beginning is an actual picture of Michael's eye. And his mom sent this to my colleague Jordan and I in an email, and she wrote something really nice in the email, or really impactful, I should say. So I thought I'd share that with you. And that is that we saw the world through his eyes, and that's how we knew he was gone. This work is very, I would say, controversial, uncomfortable, but we try to make it as family-centric as possible. In fact, many of the families continue to be patient partners. Michael's mom and dad are on our study steering committee. We meet with them regularly. In fact, they developed one of the aims, and that was the autopsy aim. So although the work is, different, we try to do it in a very family-centric manner. As evidence to that, I was lucky to be part of the scientific statement, and his parents, Michael's parents, provided a paragraph about what the work has meant to them and what their son's life meant to them and how important it was to be involved in the research. So if you get a chance, it's open access. You can read that. I'd encourage you to do so. The last thing I'll just show you is another case of a family. This is Rick. So unfortunately, Rick developed ALS and died from that. On the left is his wife, Mary. In the middle is his daughter, Mackenzie. I'm going to show you a video. Upon finding out the diagnosis that her father had a terminal illness, she made this.
284, Mackenzie.
It's about 3 to 4 minutes.
Sometimes just knowing is harder. Knowing that one day you're going to wake up and they won't be there. Sometimes I wish I could go back to that moment and say, stop, I don't want to know. But I do know it was what seemed to be just a normal night coming home. And Mom pulls me into your room and says, something is wrong. Honey, Dad is sick and he won't get better. The world went quiet. I wanted to scream, to cry. It wasn't fair. It was too soon. I know there's nothing I can do, but thoughts of anything and everything consumed my mind. If I could, I would. My only question now is, how do you say goodbye? I feel but I'm scared of what life without you's like. Why you could ever let me down? How do I say goodbye? So all I want to say is thank you. You're my teacher, my coach. Without you, I would have never been pushed into everything I love. You're the person I'm going to share stories of with my kids. You taught me to always live, love, learn, and leave a legacy. So dear Dad, thank you.
280.
Just a few acknowledgements, if I may. To do this kind of work, it's like a massive team, right? So it's me talking here, but to be honest with you, it's innumerable amounts of people who kind of coalesce around a common idea and try to make it happen. A few people I'd like to really highlight at the bottom there are the patient and family partners, Laura and David, who are Michael's parents, who continue, as I said, to meet with us there on our steering committee. And I wish I could take credit for this work. The gentleman in the picture with me is my best friend, but he's also the trainee who's he's not a trainee at all. Actually, he's my colleague who has championed this work, has done this work. His name is Jordan Bird. He's sitting in the fourth row right there. So Jordan's the smartest person I know. Sorry, John. But he's the smartest person I know. And he does this work with empathy, compassion, rigor, and a lot of passion. And I just love you to pieces. So anyways, thank you so much. And I'd happy to take any questions.
Any questions, guys?
Yes.
So 2 questions with regards to biomarkers. Number 1, we all remember CKMB from 30 years ago now or longer, but that was a biomarker, wasn't used for that, but it was more of a contamination. We were looking at a heart biomarker. So that's the first question. And then the second question is sampling for biomarkers. Are you sampling from peripheral vein or from jugular vein?
Yeah. So amazing question. Thank you for that. Let me show you here real quick.
284. Mackenzie.
And does it make a difference between jugular vein and sample?
Yeah, it does. Okay, here we go. Brilliant question. Amazing question. So yeah, we sample because the problem is like critical care is critical illness is messy. You know, let's say we get an arterial line, like, and you find a protein. I don't know where it's coming from. Like, is it coming from the kidney, the heart, the lungs, or whatever? But what we do as part of this is we sample from the jugular venous bulb, right? So, and the artery. So at the radial artery, obviously, that's going to be the same thing that's in the carotid in that point of time. So, and we sample at the same time. So before palliation, during, then post. So during, approximately about a systolic blood pressure of 60, so that the brain has undergone some sort of ischemic hit. And then we analyze the concentrations off of what's seen at the jugular venous bulb versus here. If the concentration of analyte A is higher here, then we know the brain's spitting it out. So that is how we identify what is brain specific versus what is not brain specific. Now, these are the proteins. As I said, the proteome has not changed. Initially, honestly, I was kind of disappointed, right? So I thought, identify a blood test, take it to Abbott, and then we retire, right? But that didn't work out. So having said that, though, now what we're doing starting next week is at the Life Sciences Institute is doing a metabolome and a lipidomics analysis, because those things will change quicker. Because glutamate, for example, changes. We need something that reflects exactly what we know the metabolome is changing, because glutamate is changing in the brain. So is there something that reflects question is that person dead or not? But so the key is though to replicate that glutamate rise with another analyte. And I think, it might be 2,3 phosphate, whatever. But the metabolome changes second to second. And so, we're going to get like 8,000 metabolites of stuff. And we'll see if something changes there. If nothing changes there, then I'm going to keep working for a while.
Code blue, Providence 5 alpha. Cancel code blue, Providence 5 alpha.
Yeah, amazing question.
Cancel code blue, Providence 5
Yeah.
alpha.
Thank you for that presentation. Really interesting, and it's also philosophically interesting.
Yeah.
But that maybe not as dichotomous as we thought it was. But given that everything is so discordant, your arterial line can be discordant to the cerebral pressures. Have you ever noticed that on the opposite end, where they look like they're peripherally dead, but the brain is active?
Oh yeah, for sure, right? Like, no, you're totally right. Like, especially when they get into the agonal state, in the agonal state, you also see in some patients, like, we all see in brain death, the Cushing's reflex, like that's theorized to mean a big pumping out of a lot of adrenaline. You see stuff like that in the agonal state. And so sometimes we will lose a waveform at the arterial line. So, but they're still breathing, right? So like, we try to place two art lines in some of these cases as like a backup or whatever. But yeah, of course, like none of this is perfect. So for sure, they may shunt blood to the most important organ during that agonal state. 100%, you're totally right. Yeah, and that makes sense, right? Like that's what you would want to try to sustain. Like somebody's like in the forest somewhere without anyone by. Like I don't want blood flow going to my wrist, right? Like you want it going to the brainstem so that you take another breath and then you take another breath. Yeah, you're totally right. Yes.
I'm just getting some questions from Zoom.
Yeah.
Have the findings of your work changed the way that you prognosticate after SSI, and then discuss goals of care with patients, particularly in patients who might have been in dead shock, presumably in hypoperfusing organ that gets in play?
I don't think it has changed my prognostication. I should be very clear that ethically, I don't look after these patients, so they're not my patients. They're because that's a crazy conflict of interest, right? So these are my colleagues' patients. So if there are my patients, me personally, I don't bring up the study with them.
Right.
Yeah.
I guess just in terms of your general approach to
prognostication. Yeah, no, I don't think it's changed my approach to prognostication. I don't think so. I think if anything, in critical care, we were so focused on mortality as our outcome. And now we, are focused on quality. Like, you look at some survivors of critical illness now, like, people have gone to more long-term studies, like, ECMO survivors, for example, 2 years out, they have tremendous neuropsychiatric comorbidities. Accelerated neurocognitive decline. So I think if anything, what it's shown me is, or shown us is like, geez, like, we've been kind of fixated on the wrong outcome for critical illness. And like little things like head of bed, right? Like let's say the brain is lacking blood flow for 12 hours, like sufficient blood flow for 12 hours. Geez, like they might survive, but my goodness, what are they going to be like long term, right? Like not awesome. Now we get away with it in critical care a little bit because we sedate patients. When we sedate them, metabolism goes down. So you kind of protect the brain a little bit against ischemia, but that lack of perfusion, I'm sure over the long term, especially for the first 24, 48 hours, is going to outweigh what happens, right? So I think like the downstream sequelae of what we see, like, somebody said to me, like, oh, the heart gives you quantity of life, the brain gives you quality. that's also a very philosophical statement, right? But I think that's where it's kind of changed our viewpoint is like the next frontier of, I'm biased, of critical care medicine is brain preservation. Because there is no medication for it yet. Yes.
And so when your clinical interpretation then of the cerebral fusion, how is your interpretation affected by the presence of hypothermia?
Yeah, no, without a doubt. I mean, the hypothermia trials, I think, have changed our practice. So we rarely at all ever make anyone hypothermic anymore. I can't remember in the last. So 2002 obviously was a huge year for post-cardiac arrest, critical care period, because two trials, one out of Austria and one out of Australia, demonstrated that post-cardiac arrest patients tend to do better with hypothermia. They're small. So then the Scandinavians repeated those with an 1,100 patient trial and then an 1,800 patient trial, which essentially refuted those findings. So now, I don't know about you, John or Ken, I don't think I make anyone hypothermic anymore. Yeah.
It's just not hot.
Yeah, just not hot.
So
Yeah.
the hot's bad.
Yeah, hot's bad. Yeah. I mean, like brain hot. Yeah.
We can't say that anymore.
Oh, sorry.
Thank you so much for
Okay.
really fresh take on things. We actually got a patient who just determining what's known as brain death in about 20 minutes, but we'll see. Look at it differently now. Thanks so much.
Yeah, of course. Yeah, thanks a lot.
We're gonna do the dance there. Yeah, it works. I'd like to show my interpretation. That was great.
Yeah.
Always.